Welcome back to the deep dive. We're here to basically break down complex medical topics into what you really need to know.
That's the goal.
And today, it's a big one. We're tackling the body's chemical command system, the endocrine system. We're pulling from a pretty hefty medical surgical unit covering assessment, pituitary, adrenal, thyroid, parathyroid, and, of course, diabetes.
Right. It's a huge area, but it all comes back to one central theme: homeostasis, keeping everything in balance.
How does it do that?
Well, the endocrine system uses hormones. Think of them like tiny chemical messengers. These glands, they're ductless, see? So they secrete these hormones straight into the blood.
And they travel everywhere.
They do, but they only act where they're supposed to. It's all about that lock and key model we hear about.
Explain that a bit, the lock and key.
Okay, so the hormone is the key. It floats around in the bloodstream, but only certain tissues, the target tissues, have the right lock a specific receptor site.
So the hormone only fits its specific lock.
Exactly. And when that key fits into the lock, that's when the tissue gets the message and changes its activity. It's incredibly specific.
So when this system, this balancing act, goes wrong,
Yeah.
what are the main things we see immediately affected? What are the core patient priorities?
Good question. The source material really highlights 5 key concepts that get disrupted. Think nutrition, elimination, fluid and electrolyte balance, cellular regulation, and immunity.
Those 5. Okay.
Yeah, understanding how endocrine disorders mess with those 5 areas. That's your shortcut to knowing what to focus on, what to prioritize with your patient.
Okay, so let's map out the main players here. We've got the brain's control centers,
Right, the hypothalamus, kind of the CEO, and its main deputy, the pituitary gland.
then the glands handling metabolism and stress.
That'd be your adrenals, the thyroid, the parathyroids, those little guys regulating calcium. And finally, the islet cells inside the pancreas, the ones dealing with insulin and glucose.
And when things go wrong with any of these, it usually falls into one of 3 buckets, right?
Pretty much. You've either got too much hormone that's excess or hyperfunction, or you've got too little deficiency, hypofunction.
Or the third one.
The third one is tricky. It's poor hormone receptor interaction. The hormone might be there, but the target tissue just isn't listening, isn't responding properly. We call that decreased target tissue responsiveness sometimes.
And the body's constantly trying to keep those hormone levels just right through feedback, yeah.
Exactly. It's almost all managed by negative feedback. Think of it like your home thermostat.
Okay.
If the body needs something, say, more heat, more metabolic rate, a hormone gets released to make that happen. Once the temperature is back to normal, that very condition, or the hormone product itself, signals back to the starting glands.
Like the hypothalamus or pituitary.
Right. And tells them, okay, enough, shut it down. It stops the release, brings things back into balance, homeostasis restored.
Let's use that big example from the text, the HPA axis. That really shows the layers. Walk us through that whole cascade.
The HPA axis, hypothalamus, pituitary, adrenal cortex, perfect example. Okay, imagine you're stressed. Your body needs cortisol, but levels are low.
So the hypothalamus notices.
It does, and it releases CRH, corticotropin-releasing hormone. That's the first signal.
Where does CRH go?
It travels just a short distance to the anterior pituitary, acts like a key there, telling the pituitary, release your signal.
Which is?
Which is ACTH, adrenocorticotropic hormone. ACTH then gets into the general circulation.
Finds its way to the adrenal glands.
Exactly. It locks onto receptors on the adrenal cortex, and that triggers the final step, the release of cortisol.
So cortisol levels rise. How does it stop? How does a negative feedback kick in?
The rising cortisol itself is the off switch. As those levels increase in the blood, the cortisol feeds back to the hypothalamus, telling it to stop making CRH.
And to the pituitary.
Same thing. It tells the pituitary to stop making ACTH. So the whole cascade shuts down. Production stops.
It keeps it from going too high.
Precisely. Avoids excess, avoids deficiency. It's a really elegant self-correcting loop.
All right, let's dive into Chapter 56 then. Assessment. Since the endocrine system touches everything, metabolism, fluids, growth, sex characteristics, that initial history has to be super detailed.
Oh, absolutely. You start with the basics, of course. Age, gender, those matter. Like the text points out, thyroid issues. Way more common in women.
But what's the really critical piece of history? The potential red flag.
It's got to be the drug history. Specifically, are they taking any exogenous hormones, like glucocorticoids, thyroid meds, maybe even testosterone?
Why is taking outside hormones such a big deal?
Because of that negative feedback we just talked about. If you flood the system with artificial hormones the body doesn't actually need for replacement, what happens?
The body's own production shuts down.
Completely. The glands atrophy, they shrink. Then if those outside hormones are stopped suddenly, the body has no way to make its own. You can trigger a severe secondary hypofunction. It's a huge risk.
Wow. Okay. And even simple things like changes in nutrition or elimination can be big clues, right?
Huge clues. Think about extremes. A patient comes in with this intense, almost desperate craving for salt.
Addison's disease, adrenal hypofunction.
Immediately suspected. They're losing sodium because they lack aldosterone. On the flip side, what if they're drinking constantly? Unquenchable thirst polydipsia.
Could be diabetes, mellitus, high sugar, pulling water out.
Or diabetes insipidus. The body just can't hold on to water at all. Massive fluid shifts either way.
And weight changes, rapid ones.
Always an endocrine red flag. Big, unexplained weight gain or loss often points straight to thyroid problems or diabetes mellitus because they just wreak havoc on metabolism.
We also need to think about what the body needs to make hormones.
Good point. Like the thyroid, it needs building blocks. You need enough protein. The book says at least 60 grams a day, and you absolutely need iodide.
From iodized salt or saltwater fish.
Yep. Without those basics, the thyroid factory just can't produce enough hormone.
Okay, shifting to the physical exam, what visual cues should we look for?
Look closely. Changes in hair thinning. Or maybe unusual excessive growth, like hirsutism in women, which could signal excess androgens.
Facial features too.
Definitely. Look for that prominent jaw of acromegaly, or the classic round, puffy moon face of Cushing's, or the really startling bulging eyes exophthalmos you see in Graves' disease. Even changes in secondary sexual characteristics tell a story.
Now let's pause right here. There's a critical safety warning in this section about examining the neck. A really critical one.
Yes, this is a non-negotiable nursing safety priority action alert. You never, ever vigorously palpate the thyroid gland if you even suspect hyperthyroidism.
Why not? What's the risk?
The risk is triggering a thyroid storm. Squeezing that overactive gland can cause a sudden, massive dump of thyroid hormones into the bloodstream. It's potentially lethal.
So no deep palpation. What do you do instead?
Gentle inspection, maybe auscultation. Listen for a bruit, a rushing sound that indicates increased blood flow through the gland. That's much safer.
Beyond the physical signs, these endocrine problems can really affect a person's mind and mood too, right?
Profoundly. Hormones hit the CNS hard. Assess for changes in behavior. Are they suddenly anxious, restless, maybe even manic? That could be hyperthyroidism.
Or the opposite.
Or deeply depressed, lethargic, apathetic, classic signs of hypothyroidism. And because pituitary and adrenal issues often affect sex hormones, you have to ask the sensitive questions too. Libido changes, impotence, infertility. These conditions change how people see themselves.
Okay, diagnostics. Hormone levels can fluctuate a lot. How do we get an accurate picture?
Yeah, a single blood draw isn't always useful, especially for hormones like cortisol that have a strong daily rhythm, high in the morning, low at night, or ones released in pulses.
So what's the better approach?
Often it's the 24-hour urine collection. It averages out the production over a whole day. Blood tests are still vital, of course. And for steroid hormones, saliva tests can be good because they measure the free active hormone.
The book gives really specific instructions for that 24-hour urine test. It sounds like precision is key. Why discard the first P?
That's a crucial step. When the patient first wakes up and voids, that urine gets discarded. Why? Because it was produced before the collection period started.
So the clock starts right after that first void.
Exactly.
Yeah.
Then every single drop of urine for the next 24 hours goes into the collection container. They have to do one last void right at the 24-hour mark to finish it off.
And handling the sample. Refrigeration. Preservatives.
You absolutely have to check the lab requirements first. Some need to be kept on ice the whole time. Others need a special preservative added to the jug before you even start collecting.
If you mess that up.
The whole test is ruined. 24 hours wasted. The patient has to start all over again. It's critical to get it right.
And sometimes we challenge the system directly. Stimulation or suppression tests.
Right. Provocative or stimulation tests are for suspected hypofunction underactivity. We give something that should force the gland to produce hormone. If the level doesn't rise like it should, confirms hyperfunction.
And suppression tests.
Those are for suspected hyperfunction overactivity. We give something that should normally shut the gland down. If the hormone level doesn't get suppressed, that confirms hyperfunction. Okay, let's move into chapter 57. specific glands now, starting with the pituitary, the master controller, and its huge impact on fluid and electrolyte balance. Hashtag 2.1 pituitary disorders.
Let's start with hypopituitarism deficiency. Some hormone losses are manageable, but two are flagged as potentially life-threatening. Which ones?
The critical ones are deficiencies of ACTH and TSH.
Why those two specifically?
Because they control other vital glands. No ACTH means the adrenal glands fail, leading to adrenal crisis. No TSH means the thyroid fails, potentially causing myxedema coma. Those secondary failures are the immediate danger.
And growth hormone deficiency. We usually think of kids, but what about adults? How does it affect cellular regulation?
In adults, low GH messes with tissue repair and metabolism. Specifically, it tips the balance in bone turnover, more breakdown, less building. Over time, this leads to osteoporosis, bones get thin, fragile, fracture risk goes way up.
Management is hormone replacement, often for life. What about side effects we need to watch for?
It is lifelong HRT. For men on testosterone, watch for side effects like acne worsening, maybe some male pattern baldness, and sometimes gynecomastia, which is breast tissue development.
And for women on estrogen and progesterone?
The big risks there are hypertension, and especially for smokers, a significantly increased risk of blood clots thrombosis. That's a major safety point.
Okay, let's flip it. Hyperpituitarism, too much hormone. Usually a tumor.
Yeah, most often it's a benign tumor, an adenoma in the anterior pituitary that's just churning out excess hormone. Usually it's growth hormone, prolactin, or ACTH.
Is there a genetic link sometimes?
There can be. The text mentions MEN1, multiple endocrine neoplasia type 1. It's an inherited condition that makes you more likely to develop these pituitary tumors, among others.
Excess growth hormone in adults causes acromegaly. You said the changes are gradual.
Incredibly gradual. That's why it's often missed for years. But the physical changes, once they happen, are pretty distinct and, importantly, irreversible.
Like what?
Enlargement of the face, the jaw gets prominent, features look coarser, hands and feet grow larger, out of proportion. But the really dangerous part is the internal organ growth, heart, liver. That leads to serious dysfunction down the line.
How do we treat it? There's a drug alert mentioned for one common class.
Often we use dopamine agonists like bromocriptine. Sounds odd, but they can actually inhibit GH and prolactin release from these tumors.
And the alert?
Big one. Patients need to know. If you get chest pain, dizziness, or suddenly have watery nasal discharge while taking these meds, get help immediately.
Chest pain and dizziness are obvious, but watery nasal discharge.
That's the potential sign of a CSF leak cerebrospinal fluid. If the tumor has eroded through the bone at the base of the skull, CSF can leak out through the nose. It's a serious complication.
And if they need surgery, a hypophysectomy to remove the tumor, what are the big post-op risks?
Beyond infection or maybe temporary diabetes insipidus, the main surgical risk is causing or worsening a CSF leak.
How would we know? What are the signs?
Watch for persistent post-nasal drip, or if the patient seems to be swallowing a lot, that could be CSF dripping down their throat. The absolute classic sign, though, is the halo sign on the dressing.
Halo sign.
Yeah, if CSF mixes with blood on the gauze pad, it separates out. You'll see a clear or yellowish ring, the halo around the central blood spot. That confirms a leak.
So preventing that leak post-op means avoiding anything that increases pressure inside the head.
Absolutely critical. Strict instructions. No forceful coughing, no sneezing, definitely no bending over at the waist. Teach them to bend their knees instead. And perhaps most importantly, no straining during bowel movements.
Stool softeners are key then.
Essential. You do not want them increasing intracranial pressure trying to have a BM. That could tear the surgical repair wide open.
Okay, let's shift to the posterior pituitary and its hormone, ADH. This is all about fluid and electrolyte balance, specifically the extremes, massive water loss versus massive water retention.
Exactly. Let's start with the loss, diabetes insipidus, or DI.
What's happening in DI?
Either the pituitary isn't making enough ADH, or the kidneys just aren't responding to it. Either way, the result is the kidneys can't conserve water.
So huge urine output.
Massive. We're talking polyuria of 4 liters, maybe up to 30 liters, of really dilute urine every single day. This leads straight to severe dehydration.
And what does that huge water loss do to electrolytes like sodium?
It concentrates the blood, plasma osmolarity shoots up, and you get severe hypernatremia, high sodium. The body's screaming for water, hence the intense thirst, polydipsia.
This sounds dangerous if they can't drink enough.
Extremely. Which leads to that critical nursing safety point in the text. Never deprive a suspected DI patient of fluids for more than 4 hours.
Why such a strict limit?
Because they can dehydrate so rapidly. If they can't drink to replace those massive urine losses, they can quickly go into hypovolemic shock. It's life-threatening.
Treatment involves replacing the missing hormone.
Right, with synthetic ADH, which is desmopressin, and there's a very important drug alert here about dosing.
What's the alert?
The parenteral form IV, or subcutaneous, is 10 times stronger than the oral form. 10 times. So if you're switching a patient from IV to PO, you must decrease the dose significantly or you'll cause massive fluid retention.
So patient education is vital. Daily weights.
Absolutely. Lifelong therapy. They need to weigh themselves daily, same time, same scale, and report any sudden weight gain, the book says, more than 2.2 pounds or 1 kilogram in a day, especially if it comes with headache or confusion.
Why? What does that mean?
That means the dose is too high, they're holding on to too much water. Those are signs of fluid overload, potentially water toxicity.
Okay, now the opposite problem. Syndrome of inappropriate ADH or SIADH, too much ADH action.
Exactly. Here, the body secretes ADH even when it shouldn't, like when plasma osmolarity is already low. The kidneys get the signal to keep reabsorbing water no matter what.
So they hold on to water. What does that do to sodium levels?
It dilutes the blood, you get fluid overload, but critically, you get dilutional hyponatremia. The total body sodium might be normal, but it's diluted in too much water.
What symptoms show up, especially when that sodium gets really low?
Early on, it might just be GI stuff, poor appetite, nausea. But when sodium drops below about 115 millishuol, things get serious fast. CNS changes kick in.
Why the brain effects?
Because the low sodium in the blood allows water to shift into brain cells, causing them to swell. You see lethargy, confusion, hostility, then seizures, coma. It's an emergency.
Other signs.
You might feel a bounding pulse because of the extra fluid volume. Hyperthermia is common too. Interestingly, you usually don't see much peripheral edema like swollen ankles.
Why no edema if they're overloaded?
Because it's primarily water retention, not salt in water, so the fluid tends to stay within the vascular and intracellular spaces rather than leaking out into the tissues as much.
How do we manage SIADH? It sounds like you have to be careful.
Very careful. The main treatment is fluid restriction, often limiting total intake to just 500 to 1,000 mL per 24 hours. That's tough on the patient.
Are there medications?
Yes. For more severe cases, we can use drugs called vaptins, like tolvaptan or conivaptan. They specifically block the effect of ADH on the kidneys, promoting water excretion without losing salt.
But there's a warning with tolvaptan.
A big one. A black box warning. You cannot correct the sodium too quickly. If you raise it faster than about 12 millieql in 24 hours, you risk causing central nervous system demyelination, basically, stripping the insulation off nerve fibers in the brain. Devastating, permanent damage.
And what about using hypertonic saline, like 3% ACL, for really low sodium?
That's reserved for emergencies, like active seizures. You have to use it with extreme caution.
Why?
Because you're giving a highly concentrated salt solution to someone who is already fluid overloaded. It pulls even more water into the bloodstream. You can easily push them into acute heart failure or pulmonary edema. It's a very fine balancing act. Hashtag tag 2.3 adrenal gland disorders.
Okay, let's tackle the adrenal glands now, the stress responders, starting with hypofunction Addison's disease.
Right. Loss of cortisol and aldosterone.
What does losing cortisol do?
Cortisol loss leads to hypoglycemia, fatigue, inability to handle stress.
And losing aldosterone. That impacts fluid and electrolytes, right?
Hugely. Aldosterone normally helps you retain sodium and water and excrete potassium. Without it, you lose sodium and water, leading to hypovolemia and hyponatremia. And you retain potassium, causing hyperkalemia. That combination is dangerous.
What can trigger an acute Addisonian crisis? It's life-threatening.
Often it's a major stressor infection, surgery, trauma, hitting someone whose adrenals are already weak. But a really common cause of secondary adrenal insufficiency is stopping long-term steroid therapy abruptly.
Because the steroids shut down the body's own production.
Exactly. The adrenals atrophy from disuse, take away the external steroids suddenly, and the body has zero cortisol production. Total collapse.
What are some classic signs of Addison's, besides fatigue and weight loss?
In primary Addison's, where the gland itself is destroyed, you often see hyperpigmentation. The skin gets a bronze look, especially in creases and sun-exposed areas. That's due to high levels of a related pituitary hormone.
And the aldosterone loss gives a specific craving.
The intense salt craving, that's a huge clue pointing towards that mineralocorticoid deficiency.
Management is about life support, initially fluids, fixing electrolytes. How about the hormone replacement? Is there a specific way to dose it?
Yes, for cortisol replacement, like hydrocortisone or prednisone, We try to mimic the body's natural rhythm.
The diurnal rhythm. High in morning, low at night.
Right. So typically, the patient takes 2/3 of their daily dose in the morning when they wake up, and the remaining 1/3 around 4 to 6 p.m.
And they need aldosterone replacement too.
Usually, yes, with fludrocortisone. That helps manage the salt and water balance, and they might even need to increase that dose slightly in hot weather if they're sweating a lot and losing extra salt.
Okay, now the flip side. Adrenal hyperfunction. Hypercortisolism, or Cushing syndrome. Too much cortisol. This gives a very specific look.
It really does.
Yeah.
Cortisol causes fat to redistribute. So you see truncal obesity, thin arms and legs, but fat accumulating in the abdomen, the face, moon face, and between the shoulder blades, buffalo hump.
What else does all that excess cortisol do systemically?
Oh, it's widespread damage.
Yeah.
It breaks down muscle protein, leading to weakness and thin extremities. It pulls calcium out of bones, causing severe osteoporosis and easy fractures. It causes hyperglycemia because it makes the body resistant to insulin.
But the text really stresses the impact on immunity. That seems like the biggest immediate danger.
It absolutely is. Cortisol is a powerful immunosuppressant. This means patients with Cushing's have a massively increased risk of infection.
And they don't show the usual signs.
Exactly. The inflammatory response is blunted. They might have a raging infection, but no fever, no redness, no pus. The signs are masked.
So what's the rule for monitoring them for infection? It has to be different.
It has to be hypervigilant. Even a tiny temperature elevation is significant. The guideline is often a rise of just 1 degree Fahrenheit or half a degree Celsius above their baseline needs to be investigated immediately as a potential sign of serious infection. Prevention is key.
Diagnosis involves proving cortisol levels are high and don't suppress normally. If surgery, like removing an adrenal tumor, is needed, what's the main pre-op focus?
Getting them as stable as possible before the stress of surgery. That means correcting fluid and electrolyte imbalances, especially getting potassium levels normalized.
Why potassium specifically?
Because abnormal potassium levels high or low drastically increase the risk of dangerous heart rhythm problems during anesthesia and surgery. You also want their blood sugar under the best possible control for healing.
All right, moving on. Chapter 58. This is where, as you said, it gets really interesting. We're hitting the thyroid-controlling metabolism and cellular regulation and the parathyroids, managing calcium. Hashtag 3.1 thyroid disorders.
Let's start with hypothyroidism. Low or no thyroid hormone. This means everything just
Yeah.
slows down. It's a fundamental decrease in cellular regulation everywhere.
There's a specific physical sign associated with severe long-term hypothyroidism, myxedema. What causes that?
Right, myxedema. It's a weird one. Because metabolism is so slow, the body can't properly break down these large molecules called glycosaminoglycans, or GAGs.
GAGs.
Yeah. They build up inside cells, and they attract water. This causes this characteristic non-pitting edema, a sort of doughy swelling. You see it in the face, making it look puffy, in the hands, feet, even around the larynx, which causes that typical husky, gravelly voice.
And the other symptoms just reflect that global slowdown.
Exactly. Slow heart rate, bradycardia, can't tolerate activity, low blood pressure, feeling cold all the time, cold intolerance, weight gain, even if they're not eating much, constipation, depression, apathy, thinking, and speech become slow and sluggish.
And the extreme emergency state.
That's myxedema coma. It's a critical failure of heart, lung, and brain function due to extreme hypothyroidism, often triggered by stress, infection, certain drugs. Mortality is terribly high.
Treatment is lifelong thyroid hormone replacement, like levothyroxine. But there's a big caution, especially when starting it in older adults.
Huge caution. You have to start low and go slow, especially in the elderly or anyone with heart disease.
Why? What's the danger of starting too high?
You're suddenly revving up their metabolism. That increases the heart's oxygen demand drastically. If you do it too fast, you can precipitate angina, heart failure, even a heart attack, MI. Titration has to be very gradual.
Okay, let's speed things up now. Hyperthyroidism. Too much thyroid hormone. Often Graves' disease, right?
That's the most common cause, yes. Graves' disease is autoimmune. The body makes antibodies called TSIs that mimic TSH and constantly stimulate the thyroid gland to overproduce hormones.
So metabolism kicks into overdrive.
Way into overdrive. It causes thyrotoxicosis. The body starts breaking down protein faster than it can rebuild it, a negative nitrogen balance.
Symptoms of the complete opposite of hypovan.
Pretty much. Intense heat intolerance, they're always hot. Weight loss, even though they're eating more. Heart racing, tachycardia, sometimes irregular rhythms. You might notice a widened pulse pressure. Find tremors in their hands. They're restless, anxious, maybe even seem manic.
And Graves has those specific eye signs.
Right, the exophthalmos, those bulging, staring eyes, that's caused by swelling in the tissues behind the eye. It can be severe enough to damage the cornea, and sometimes they get pretibial myxedema too, a rash on the shins.
And just to hammer it home one more time, the physical exam safety point.
Diagnostics show high T3, T4, usually very low TSH. And again, do not palpate the goiter. Cannot stress that enough.
What about the crisis state here? Thyroid storm.
That's the hyperthyroid emergency, life-threatening. Key features are extreme high fever, like 105, 106 degrees F, and severe hypertension. It can be triggered by infection, trauma, surgery, or, yes, vigorous palpation of the gland.
What do you do immediately?
Airway first, always. Support breathing. Aggressively cool them down, cooling blankets, Tylenol for fluids. Beta blockers to try and control that heart rate and blood pressure. It's an all-hands-on-deck emergency.
If they end up needing surgery, a thyroidectomy, what are the big post-op worries after the immediate risk like bleeding or airway swelling?
Once you're past the initial hours, the major concern shifts to the parathyroid glands. They're tiny, located right behind the thyroid. It's very easy to accidentally remove or damage them during thyroid surgery.
And if the parathyroids are gone or damaged?
Then PTH levels plummet and you get acute hypocalcemia. Low calcium. This leads to neuromuscular irritability, tetany.
So, post-thyroidectomy, we're watching calcium like a hawk.
Constantly. Hourly checks initially for early signs. Tingling around the mouth, perioral tingling, tingling in the fingers and toes, any muscle twitching.
And checking those specific signs, Chvostek's and Trousseau's.
Yes. Actively check for Chvostek's sign, tap the facial nerve, see if the face twitches. And Trousseau's sign, inflate a blood pressure cuff on the arm and watch for the hand wrist to spasm. If you see those, or if they have active spasms, you need calcium replacement fast.
Have it ready.
Absolutely. For V-calcium gluconate or calcium chloride needs to be immediately available at the bedside for emergency administration. Hashtag tag 3.2 parathyroid disorders, calcium phosphorus regulation.
Okay, let's focus on those little parathyroid glands. They operate independently of the pituitary, right?
Yeah.
Just focused on calcium.
And phosphorus. Parathyroid hormone, PTH, is all about raising serum calcium.
How does it do that?
3 ways. It tells the bones to release calcium, it tells the kidneys to reabsorb more calcium and excrete phosphate, and it helps activate vitamin D, which boosts calcium absorption from your food in the gut.
And calcitonin from the thyroid does the opposite.
Right. Calcitonin lowers calcium. They work in opposition to keep levels stable.
So hyperparathyroidism means 2-inch BPH, leads to
Hypercalcemia, high calcium, and, because of the kidney effect, hypophosphatemia, low phosphate.
What does high calcium do to the body? What are the symptoms?
Think stones, bones, abdominal groans, and psychiatric overtones. High calcium can cause kidney stones. It weakens bones, osteoporosis. It causes GI issues like constipation, nausea. And in severe cases, it affects the brain, fatigue, confusion, even psychosis or coma.
How do we manage that high calcium?
Get it out. Lots of 5E fluids. Hydration is key. Then, diuretics like furosemide are often given with the IV saline to force the kidneys to excrete more calcium.
And safety, given the weak bones.
Huge safety issue. Prevent fractures. Use lift sheets for repositioning. Handle them gently. They are at high risk for pathological breaks.
Now, hyperparathyroidism, not enough PTH. So low calcium.
Right, hypocalcemia. If it's acute and severe, like after thyroid surgery, they need IV calcium right away.
Long-term management.
Oral calcium supplements and vitamin D, usually for life. Vitamin D is crucial because it helps them absorb the oral calcium.
And there's a really specific dietary instruction here, isn't there, about phosphorus?
Yes, this is a key nutrition tip. Because low PTH also means that the kidneys retain phosphorus, these patients need a diet that is high in calcium but low in phosphorus.
So what foods should they avoid?
They need to avoid milk, yogurt, and processed cheeses. Those are loaded with both calcium and phosphorus. It's counterintuitive, but it's essential to prevent dangerously high phosphate levels. Okay, chapter 59, the big one. We're shifting to the pancreas and the most common endocrine disorder by far. Diabetes mellitus, all about impaired glucose regulation.
So DM, chronic high blood sugar, either not enough insulin or the body isn't using it right, or both. Remind us quickly of the roles of insulin and glucagon.
Insulin is the key that lets glucose get into cells for energy or storage. It's released mainly when you eat. Glucagon does the opposite. It raises blood sugar, mostly by telling the liver to release stored glucose. It works when you're fasting or stressed, prevents hypoglycemia. It's a constant balancing act. Hashtag tag 4.1 pathophysiology of hyperglycemia.
When that balance fails and there isn't enough insulin action, glucose piles up in the blood and the cells starve. That leads to those classic 3 Ps.
The classic triad, yes. Polyuria. Excess glucose spills into the urine and water follows it out, so lots of urination. Polydipsia, all that urination causes dehydration, making you incredibly thirsty. And polyphagia. The cells are starving for glucose, so they send hunger signals, making you want to eat more even though blood sugar is high.
And if there's no insulin, like in type 1?
And then the body starts burning fat for energy like crazy. This produces acidic byproducts called ketones. They build up, cause metabolic acidosis, and that's diabetic ketoacidosis, or DKA.
What are the 3 big acute emergencies we see with diabetes?
You've got DKA, which we just mentioned, ketones, acidosis, usually type 1. Then there's hyperglycemic hyperosmolar state, or HHS. This is more common in type 2. It's characterized by extremely high blood sugar and severe dehydration, but usually without significant ketones or acidosis.
And the 3rd?
Always lurking hypoglycemia. Low blood sugar, usually from too much insulin or medication or not enough food.
Let's talk long-term damage.
Oh.
Chronic high blood sugar hurts blood vessels everywhere.
Yeah, absolutely everywhere. It thickens vessel walls, causes direct glucose toxicity, leads to poor blood flow, chronic ischemia. We divide the complications based on vessel size.
Macrovascular, big vessels.
Right. That means increased risk of cardiovascular disease, heart attacks, strokes, and peripheral vascular disease. Poor circulation in the legs. This is why aggressive control of blood pressure and lipids is so critical for people with diabetes. The target BQ is usually less than 40/90 and LDL cholesterol less than 100.
And the microvascular complications. Tiny vessels. Those are really damaging.
Devastating. They lead to organ failure, diabetic nephropathy, kidney damage. It's the #1 cause of end-stage kidney disease requiring dialysis or transplant. High blood pressure and high glucose hammer the kidneys.
Lies.
Diabetic retinopathy, damage to the blood vessels in the retina. The worst form is proliferative retinopathy, where fragile new blood vessels grow and bleed easily. Macular edema, swelling in the center of the retina, is a major cause of vision loss.
And
Diabetic neuropathy can affect peripheral nerves, DPN, causing pain, numbness, tingling, and eventually loss of protective sensation in the feet, which is a huge risk factor for foot ulcers and amputation.
it can affect autonomic nerves too.
Yes, autonomic neuropathy. That can cause all sorts of problems. Silent heart attacks, painless MIs, orthostatic hypotension, dizziness when standing up, gastroparesis, delayed stomach emptying causing nausea and unpredictable blood sugar. #tag 4.2, management of DM.
Okay, managing DM. How do we track long-term control besides daily checks?
The gold standard is the A1C, or glycosylated hemoglobin. It gives you an average picture of blood sugar control over the previous 2-3 months.
What are the numbers?
An A1C over 6.5% generally diagnoses diabetes. Between 5.7% and 6.4% is considered pre-diabetes. For most people already diagnosed, the goal is usually an A1C below 7.0%.
And day-to-day, finger sticks are still key.
Self-monitoring of blood glucose, SMBG, is essential, especially for anyone on insulin. Continuous glucose monitors, CGMs, are amazing tools too, giving real-time readings.
But CGMs aren't perfect. There's a lag time.
Right, they measure glucose in the fluid between cells, not directly in the blood. So there's a delay, maybe 5-15 minutes, especially when blood sugar is changing rapidly. They also still need calibration with a finger stick, usually once or twice a day, to stay accurate.
Let's hit some key drug alerts. Metformin, the most common starting drug. What's the big risk?
Metformin works mainly by reducing glucose production from the liver. The major drug alert is the risk of lactic acidosis, a rare but serious side effect, especially if kidney function is poor.
So when should it be held?
Absolutely critical. Hold metformin before and for 48 hours after any procedure using IV contrast dye and before major surgery. You need to confirm kidney function is okay before restarting it.
What about the TZDs, the glitazones? There's a heart failure warning.
Yes, a big black box warning. TZDs like pioglitazone, rosiglitazone increase insulin sensitivity, but they can cause significant fluid retention, which can worsen or trigger heart failure. They also increase fracture risk. They're generally avoided in anyone with symptomatic heart failure.
And the newer SGLT2 inhibitors. They make you pee out sugar. Any specific warnings highlighted?
Like canagliflozin, very effective drugs. The main safety flag raised in the source is an association, particularly with canagliflozin, with an increased risk of lower limb amputations. It just underscores how vital foot care is.
Okay, insulin. High alert medication, lots of room for error. Let's talk timing and technique.
Lag time is crucial. Rapid-acting insulins, like Lispro, Aspart, work fast, so they need to be injected maybe 10-15 minutes before eating, or sometimes right with the meal.
Regular insulin.
Regular is slower. It needs a longer lead time, usually 20 to 30 minutes before the meal, to be working when the food starts hitting the bloodstream. Get the timing wrong, and you risk high or low blood sugar.
Injection technique. Angle matters.
It does. Most average-sized adults use a 90-degree angle, straight in. But for very thin individuals or children, you might need to use a 45-degree angle and maybe pinch the skin to make sure the insulin goes into the subcutaneous fat, not the muscle underneath. Muscle absorption is much faster and less predictable.
Let's wrap up management with maybe the most important prevention strategy. Foot care. Why is it so critical?
Because, as the source states, most lower extremity amputations in people with diabetes are preceded by a foot ulcer. And those ulcers happen mainly because of neuropathy, loss of feeling, and pressure.
So prevention is everything. What are the key steps?
Daily foot inspection. Every single day, including between the toes. Use a mirror if needed. Wash feet daily with lukewarm water, dry thoroughly, especially between toes. Apply lotion, but not between the toes that can breed fungus.
Shoes.
Critically important, get professionally fitted shoes. They should be about 12 to 58 inch longer than the longest toe to allow room. Never go barefoot, ever, not even indoors.
And that filament test.
The Semmes-Weinstein monofilament test. It uses a specific amount of pressure, 10 grams. If the patient can't feel it on various spots on their foot, they have lost protective sensation. They are at extremely high risk for injury they won't even feel. Hashtag 4.3, managing acute complications.
Okay, let's quickly review managing those acute problems. Hypoglycemia, the 15-15 rule. Remind us.
First, know the symptoms. They usually start neurogenic, shaky, sweaty, anxious, heart pounding. Then, if it gets worse, neuroglycopenic confusion, slurred speech, drowsiness, eventually seizures or coma.
What's hypoglycemic unawareness?
That's dangerous. It's when someone, often with long-standing diabetes, loses those early warning symptoms. They can go from feeling fine to severely confused or unconscious very quickly.
So if someone's low, BG70, but conscious, what's the rule?
Give 15 grams of fast-acting carbohydrate, that's like 4 ounces of juice or regular soda, or 3-4 glucose tablets. Wait 15 minutes, recheck blood sugar. It's still low, repeat.
What if it's really low, like under 50?
Might need 30 grams of carbs initially. Liquid carbs work fastest.
And if they're unconscious?
Can't give anything by mouth. Need glucagon injection, IM or SESQ. Have someone ready to turn them on their side, as glucagon often causes vomiting. Or, if in a healthcare setting, IV dextrose, D50.
Let's briefly contrast DKA and HHS again, the key differences.
DKA. Typically type 1 involves ketones and acidosis. Blood sugar might be high, but not always astronomically high, maybe 300, 500. HHS. Typically type 2, often older adults. Blood sugar is extremely high, often 600, even over 1,000. Severe dehydration leads to high serum osmolarity, but minimal or no ketones acidosis.
Treatment priorities for both. They start the same, right?
Yes. Priority number 1, fluid resuscitation. Restore blood volume and perfuse tissues. Usually start with a bolus of normal saline, 0.9% ACL.
Then what?
Priority 2, replace total body fluid losses more gradually. This often involves switching to hypoconic fluids, like 0.45% ACL, once blood pressure is stable, to rehydrate the cells. But you have to monitor incredibly closely for fluid overload, especially in HHS, and watch for signs of cerebral edema, which is rare but deadly.
Insulin comes next.
Right. Usually continuous IV infusion of regular insulin, started after the initial fluid bolus.
But potassium is the tricky electrolyte here.
The trickiest. Both the fluids and the insulin drive potassium into the cells, so the serum potassium level can drop very quickly, even if it was high initially. This risks dangerous heart rhythms.
So when do we start replacing potassium?
Usually once the serum K+ level falls below 5.0 MEQL and you know the kidneys are working. Which brings us to the final critical action alert.
Which is?
You must ensure the patient has adequate urine output, at least 30 mmol per hour, before you give any IV fluids containing potassium. If the kidneys aren't working, giving potassium can cause life-threatening hyperkalemia very rapidly. Hashtag tag outro. Wow, that was a lot. But you can see how it all ties back to homeostasis. We saw the critical need for fluid and electrolyte balance with the pituitary and adrenals in chapter 57.
Right, and the extremes of metabolism demanding precise cellular regulation with the thyroid in chapter 58.
And then the huge lifelong challenge of glucose regulation and preventing complications in diabetes from chapter 59, it all connects.
So the big takeaway for you, the listener, it's really about understanding why things happen, the pathophysiology, so you can prioritize care effectively.
Exactly. Knowing why you need meticulous fluid monitoring in DI or SIADH, why infection prevention is paramount in Cushing's, why foot care is non-negotiable in diabetes. That deep understanding is what leads to safe, effective care.
Okay, final provocative thought for you to chew on. We talked about those complex feedback loops like the HPA axis controlling cortisol.
Yeah, CRH triggers ACTH, triggers cortisol, which then shuts off CRH and ACTH.
So think about that. A tiny problem in one small gland, like the pituitary, can ripple outwards and cause a massive life-threatening crisis across multiple body systems like we see in an Addisonian crisis or myxedema coma.
So the question is, how does really understanding that profound interconnectedness change the way you think about any disease? Does it make you look beyond just the affected system?
Something to ponder. Thank you so much for joining us for this deep dive. We really hope this helps you feel well-informed quickly.
And from all of us on the Last Minute Lecture team, thanks for listening. Stay curious, keep learning,